Welcome to the ABCT Presidential Address. Before I do a proper introduction of President Steketee, I have a few housekeeping items that I want to review with you. First, please turn your phones on vibrate. Please make sure that you complete the evaluation form from this meeting. You will receive an email tomorrow with a link, and I can assure you that all of our convention committees will take your feedback very seriously. Next year is our 52nd annual convention, and the meeting will be held in Washington, D.C. at the Marriott Washington Wortman Park. So please make sure you mark your calendars that the meeting is from November 15th through the 18th. And then come to the Saturday night party. The local arrangements committee has arranged for a fabulous DJ, and there will also be a photo booth. The party starts at 10:30 p.m. in the Sapphire Ballroom, and that's right next to this room right here. And then we ask that you stay seated at the end of the presidential address, because I will be presenting Gail with a gift from the association for her amazing leadership and wisdom as our president over the past year. And now it's time for the ABCT selfie. So let us get a photo, and then you can start tagging yourself on the ABCT Facebook page. Actually, let me just put that down. Closer. This way. Okay, great. Now you do Jordana.
The next order of business is that it is my pleasure to thank with tremendous sincerity my colleague Dr. Jordana Muroff, who was program chair for this meeting. So if you've thought that it was a good meeting, please give her a hand. Jordana.
It's a real pleasure to introduce Gail Steketee, but before I do so, I want to thank the people who have helped me put this introduction together. I know, right? So, let me start by talking a little bit about Gail's education and her career. Gail received her undergraduate degree from Radcliffe, which at the time was the female version of an all-male Harvard. Then she went on to receive her master's degree and PhD in social work from Bryan Mara. She completed her internship at Temple, where she later joined the faculty as a research associate. And in 1986, she accepted a position as an assistant professor at the Boston University School of Social Work, where she was quickly promoted to professor, and later on also as dean. And even though Gail is a dean and she was such a strong administrator and leader, she's also an incredibly productive researcher. She has given tons of talks. She has over 175 publications, mostly on hoarding, and then she has written books. Take a look at those books. And many books. So if you get all of these books, you can get your own hoarding collection started yourself. But writing all of these books is a ton of work, and fortunately, Gail didn't have to do it all by herself. She had some really productive collaborations over the years. And here is Randy Frost. So Gail had a really wonderful and very successful collaboration with Randy. As a matter of fact, they were so successful together that we started calling them the king and queen of hoarding. Gail and Randy also won a number of awards, and Gail also won some awards by herself, and she has been super active within the ABCT community. Not only as a presenter and reviewer and program chair, but here you can see her at the 2010 World Congress of Cognitive Behavioral Therapy, which she organized in Boston. As you can see, Gail always shows up dressed in style. So a little bit more on the personal side, it all began, it's cute, right? It's cute. It all began in Detroit, Michigan, and then later on, when Gail was 2 years old, her family moved to Toledo, Ohio. And this is actually such a great picture because if you know Gail, you know that she's incredibly feisty. And this picture sort of explained it for me, right? Because Gail was the only girl with 3 brothers. So now we know where it all came from, Gail. And these are the guys now in Gail's life currently. There's Brian, to whom, Brian right there, to whom she has been married since 26 years. And here is their son, Brendan, and his partner, Katie. And here is the latest new little guy. This is Brendan and Katie's son, and he was just born a few days ago on November 6th. So congratulations, Gail and Brian. So Gail doesn't only like humans, she also really likes dogs. And here you can see her. This is such a Gail-like posture. You know how all the dogs are admiring her in this photo. Besides humans, Gail also likes nice clothes. And Gail has her very own sense of fashion. This is a picture, I think it's around middle school age, you know, and even there, take a look at these funky classes. So her sense of style developed very early. But Gail is dressed perfectly for any occasion, no matter if it's like going to the beach, or if she's going to some vintage dance party, doesn't matter. Gail always has the right outfit. But Gail has so many facets, and my personal favorite is that you are such an incredible mentor, Gail. And for those of you from Boston, this will be familiar. This is a Boston Duck Parade, and of course, Gail is a mama duck. And then you see all of the little ducklings with her mentees' heads superimposed, you know. And actually, we ran out of ducklings. There are more mentees. But you recognize many of the faces. So duckling number 1 is Jordana, our current program chair. There's Christiana, Barbara von Oppen, and so many of us. And it was great for us to have Gail as a mentor, because all we needed to do was really just follow her around. So we just did what she did, right? So Gail gave talks, we gave talks. Gail wrote papers, we wrote papers. Gail wrote grants, we wrote grants. And then Gail ran for ABCT president. I'm like, oh no, I have to do that too. Yes. Anyhow, my favorite mentoring story of Gail actually also involves Jordana, and this is now a few years ago. But this, and you know, the one right here, I don't know if this works. Okay, the one with a little bump on the stomach, that's Jordana, and the other one is Gail. And Gail and Jordana were sitting down several years ago for a budget meeting, and Jordana was super pregnant at the time. But anyway, they're sort of working away at their budget, and they're making good progress. And then all of a sudden, Jordana says, the baby's coming. Like right now. And Gail didn't even... And Gail didn't even blink an eye. In her typical Gail Steketee fashion, she packs Jordana in her smart car and whisks her away to the hospital. Within 20 minutes, that baby was born, right? So this is such a Gail Steketee story, because she handles anything efficiently, no matter what challenge might arise. So you can probably imagine my shock and surprise when Gail announced a few months ago that she was thinking about retiring from BU. And I couldn't even picture it, because in my mind, Gail was just going to work forever. And now all of a sudden she says she wants to leave. And of course I said, congratulations, Gail. But what I really felt was oh boy, what are we going to do? And then Gail said, not to worry, she was still going to be around, she was going to continue to be involved in ABCT, and she would keep holding that ABCT flag. So we can all relax, she's going to be with us for quite some time. But anyhow, please join me in welcoming the vintage fashionista, the Uber mentor, the queen of hoarding, our ABCT president, the incredible Gail Steketee.
Thank you for that incredible introduction, Sabina. That was amazing. It is my pleasure this evening to talk to you about the work we've been doing over the last couple of decades on hoarding disorder, and I called it Team Science because of what it has felt like. So this is a thank you to my many, many colleagues who've worked with me in this work. And what I thought I'd do is start with a few career comments, because Sabina's right. I'm in my final sabbatical year, and then I will retire and I'll be an emerita faculty member, which doesn't mean I'll stop working with all of you. It's just I'll stop working with people I don't really want to meet with. Thank you very much. And so it'll have been a 40-year period as a clinical researcher at Boston University for most of those years, and before that at Temple University, where I get to look back to my fine mentors who assisted me in that process, Edna Foa, Joe Wolpe, Alan Goldstein, Leslie Alexander, and several others. Some terrific colleagues I'm looking back on with across the disciplines who have enriched my career and my personal life. I look back with surprise and satisfaction for a very interesting academic career. I had no idea I would do this when I was in college and even in graduate school as I got my MSW. Tremendous pleasure at the mentoring process of students and my early career colleagues, and much appreciation for the achievements and the challenges in our research and practice on mental health conditions. I look forward to learning new things in academic and non-academic pursuits. I have to say a grandchild is pretty compelling. And continuing to lend a helping hand with various projects that my colleagues here are working on. And so what I thought I'd do is give you a bit of a whirlwind tour of hoarding over the past 20 years of studying this new mental health condition, hoarding disorder. And of course, I'm going to cross some segments of that work in terms of the psychopathology, some of the assessment, etc., multiple disciplines and contexts, and perhaps a few insights about working on a new mental health condition. One of the students I spoke with this morning thought that one of the new mental health problems is likely to have something to do with the internet and technology and managing our compulsion to pay attention to these things. So I think there are probably some new conditions that will be discovered. Beyond the work I present here tonight is a tremendous amount of additional work by these colleagues I'll speak about and others that I won't have a moment to speak about. So I thought I'd tell you that what I'm aware of, oh, that went an interesting place. Oh, hold on. Let's see if I can find that. It's not going to do that. We'll find out. There we go. So Randy and I have said to each other that studying hoarding has been like trying to catch up with a freight train, because no sooner had we begun to make it known than many, many people needed to talk to us about this problem. Not always the people who had the problem. So it's been an interesting experience. And the truth be told, it's all Randy's fault. He's sitting up front here, and he knows that. And I tagged along for the ride. So we had been working on OCD, and as this became important, or seemed to be important, he said, maybe we better pay attention, and we did. And then we dragged Dave Tolan into the mix, who's also down here. And together as a team, actually, we've been a pretty good team. We've had several grants, a bunch of articles, some books that we wrote, and I think we're pretty pleased with ourselves. And then in addition to the work that we've done, Jordana and Christiana from Boston University have worked with me closely on this. A host of others, Kiara's down front here, Catherine Ayers, Mike Kyrios, who could not make it to this meeting, Jessica Grisham, Sheila Woody, who's down front here. Gary Petronik would not come to this meeting, but he's a veterinary medicine doc who dragged us into some of the work on animal hoarding. Jesse Edsel-Vetter, working on housing aspects, housing inspector who moved into work on hoarding. And Lee and Beck Schur, who are part of the peer support group that has worked on this problem, and a small village of other people whom I won't name. You'll see a few of these names pop up in the talk that I'll give, but I wanted to make it clear just how many people it takes to move a field forward in this kind of way, and we came in at different points, but we've all worked closely together, and that's been wonderful. This is classed as a disclosure slide, but you've already seen these books and some others on OCD. And so we've had the pleasure of support by Oxford to write these books, which have been very helpful to us and to people we think with hoarding. And we've had a good bit of research funding that has helped launch our work. The International OCD Foundation started us off back in '97 with some funding for our first treatment, which was a group treatment plus an individual case, which was the first publication on treatment that we did. And then Compulsive Hoarding Among Elders in 2002 was another support grant that they provided us with. And the National Institute of Mental Health has also supported our work. I want to call attention to the fact that they did it in backwards order from our experience. So we first wrote the study for psychopathology because we didn't really understand the problem well enough. And it took the third cycle to get that funded. So that actually got funded. As soon as we wrote that grant, we wrote the treatment grant thinking, oh, this will attract people into the lab. We had better have something to deal with them to figure out how to help it. So we wrote the treatment grant. That group funded it right off the bat, first time through, and it took a long time to get the psychopathology grant. So I don't recommend that order if you can avoid it. The evolution of the work on this problem may have relevance for some of the other mental health conditions that we know to be challenging ones. And I list a few up here: OCD, BDD, eating disorders, serious mental illness, etc. There are a number of others that might fit the model, where the scientific process for understanding and treating it effectively needs many players involved. This is much broader than a pure clinical treatment, and you'll see me harp on that a little bit because of the involvement needed by the other contextual groups that deal with hoarding problems. It's been more than 20 years on it at this point, but we're still very much a work in progress. And what I'll give is a few highlights of that progress. So hoarding is a problem that spans the ages, as our hunter-gatherer hoarder here emerges on the scene. And it's a problem for the young, as Dennis the Menace says, I know it's good for something, I know it's good for nothing, but I'm keeping it until it's good for something. And a problem for the old, as she lays her wares out for a yard sale that nobody is interested in, and Catherine Ayers knows this all too well. So who is involved in the problem? Of course, the person who has a hoarding problem. And us mental health providers, we're certainly square in that camp. Family members are very much involved in the process. And then we have this array of service providers who bump into it in many ways. And then we have the rest of the family, friends, household, landlords, etc., who are also involved. And so by the time you're done, you have this pretty much a crowd of people who know about and need to deal with the hoarding problem. So that's been our experience in doing research on this problem. Randy and his students provided the first significant understanding of this problem, and what we know at this stage of the game is that clutter is merely the manifestation of the problem. It is not the problem itself, although it creates problems by itself. But clutter results from the excessive acquisition, saving too many things, and the disorganization that goes along with that. And then Randy and he and Tam Hartle defined hoarding as the acquisition of and failure to discard a large number of possessions, with living spaces so cluttered that they couldn't be used as they were intended, and significant distress or impairment caused by the clutter, which then, of course, formed some of the basis, and I'll show you that DSM-5 momentarily. But I want to show you just a little snippet. Randy and I use this in our training all the time. This is one of his early cases, And it appears in our book Stuff in some detail, and Randy did a terrific job on that segment of the book. And so this is a kitchen, her kitchen, and the kind of thing that you notice in a situation like this is that that is the stove behind you with a tea kettle on it and a pile of papers right next to it, but it's a gas stove. And you go, oh dear. You can't see the sink very well there, but it is full of dirty dishes. And so we're verging on a problem, and all you can do in this kitchen is sit in that one seat in the corner and have a breakfast. But it's a family's household, so there's only one person can sit in this kitchen. Here's the dining room with a different collection of stuff. And then as you go into the TV room, you have yet another collection of, in this case, newspapers. And what you see is the effort to organize along the back couch area there, in which all that's happened is that the piles have been repiled in a different order. So a bit of churning going on, as we've called it. David Modish-Coles has been very, very helpful in helping establish DSM-5 as the repository for the first hoarding disorder diagnosis in the field, which has its problems potentially, but is also extremely helpful to people who have the problem and those who are trying to assist with it. So the definition, as you see on the left there, is difficulty discarding, need to save, clutter, distress, or impairment. As we know, that's a little unusual because normally you have distress and impairment, but now and again you don't have both because people don't recognize the problem, not due to another medical condition or another DSM-5 disorder. There are two specifiers, and I'll go into those. This is the one on shopping. Some highway driving can increase acquisition if you're not careful. What we know about acquisition is that it does occur in the vast majority of people who hoard, but although it may not necessarily be current. So current is about 60%, past acquisition, another 28%, and there's only 8% in the population that we diagnosed pretty carefully here. This is about 212 folks with hoarding disorder, and only 8% do not have a current or past acquisition problem or avoidance. In terms of the insight specifier, what you find is that hoarding is quite a bit worse on the Y-box insight item than you would find in OCD. So you can see those bars are very different, with hoarding having many more in the fair, poor, and delusional realm compared to OCD, where excellent and good is the majority of people that we treat. So this is quite a different condition that we need to think about a little bit differently. Animal hoarding is now known as a special manifestation in the DSM-5. The problem we have is we don't know a great deal about it. Gary Petronik did an excellent job of defining it as the accumulation of a large number of animals, and we used 20 plus in our studies in order to find a number that we could work with. Failure to provide minimal care standards, failure to act on deteriorating condition of the animals and condition of the environment. And so we've worked closely with a number of folks on the Hoarding of Animals Research Consortium over the years, but the research in this area is still very much in its infancy. It is a hard problem to study because it also has a criminal conviction associated with it that one has to deal with when you're trying to work with people with the problem. So what do we know about hoarding at this stage of the game? And again, I'm only going to give you a small smattering of this. The prevalence, there have been several studies on it. These are several of those. And what we conclude at this stage of the game is that depending on how strictly you diagnose it, you're probably going to end up with about 4% of the population. That's a very big number. So it's quite a serious problem. And when I speak to public audiences about it and clinical audiences, if I ask who knows someone in their personal life with a hoarding problem, it's common to see well over 50% of people raising their hands about that. So that gives you a flavor of just how frequently this problem occurs. Age of onset is quite early in the game. So this is just one study. There are several others that people in our group and other groups have done. And what you see is that the high bars there are representing the ages anywhere from 10 up to 25, with the mean age somewhere in the early teenage years. So it's a problem that sets on early in life, but what happens is that it doesn't build to be severe enough until somewhere in the 20s, 30s, and pushing into the 40s, where it's moderate to severe, and then you see it level off at those later years in the 50s. So the vast majority of people that we see in the clinic when we call for people to participate in the research or treatment studies is going to be in the 50s, typically, as a mean age. That's very, very different than a lot of the problems we deal with in terms of anxiety disorders, depression, eating disorders, etc., substance abuse disorders. Hoarding is also very high on the work impairment end of things. That's our red bar there. These are the number of days in the past month that there was a problem with the employment. And what you see is that that bar matches the bipolar and psychosis end of the spectrum. So it's quite severe, and when you happen to glance at studies that are done on this, you find that a lot of people are unemployed or underemployed who have this problem. The hazards of hoarding are very high. Poor sanitation is a consequence. Mobility, we see a number of stairwells that are completely cluttered, blocked exits so that no one can get in and out of that particular door, and creates a problem for medical emergencies. Community costs can be very, very high, especially when they try some cleanouts. Homelessness can be a consequence, and fire hazard and death, and that happens to be a house that is in my own community, where an 82-year-old man died in that fire because the fire department couldn't get to him in time. Why do people save? What and why do they save? And so the types of items that they save, if you look at the top list, it's ordinary. We all have clothes and newspapers, books and containers. And they save things that are of high and low value, and that's a little bit different. So the deed to the car can be mixed in with the gum wrappers, the $100 in the envelope in cash, and the sock with holes in it. And the reasons for saving are, again, very, very similar to why all of us would save. So there's nothing unique about this, except perhaps the intensity of it for certain types of objects. Sentimental saving, where there's a strong emotional attachment, instrumental saving, where it's useful, and intrinsic, because it's beautiful. The comorbidity in hoarding disorder is quite high, and this just shows the mental health comorbidity. The physical comorbidity is also high. But here we have MDD, major depressive disorder, being a very strong comorbid problem at about 50% in the group of patients we studied. There are other studies where it's down closer to the 30 or 40% range. Generalized anxiety, social anxiety is common, attention deficit conditions, with OCD being lesser but higher than you'd expect on average. And post-traumatic stress disorder relatively low despite histories of traumatic experiences by people with hoarding. And there are many associated features that we've begun to investigate. Yes, you think this is bad, you should see the inside of my head. Where attention, memory, executive functioning, we have studied a bit of that. I don't have time to present any of those findings, but clearly there's some interesting things going on there that we want to pay attention to. And genetic features, these are just a couple of the studies. There are some others. I've seen a little bit of stalling here. We're not seeing quite as much. Yes, Eureka, I may or may not have found the gene that causes indecisiveness. And that's sort of the challenge. When we find the gene, what is that gene about? It's not about hoarding per se. It's about something that's contributing to hoarding. And extensive research by many of my colleagues on the features of hoarding disorder. Medical illness, I just mentioned that there's a higher rate of various medical problems, including overweight. Emotional problems with anxiety, sensitivity, distress tolerance, and you see some of the studies that these colleagues here have done. Behavioral and research on behavioral aspects of hoarding, in which there are experiential avoidance, behavioral self-control problems, and neuroimaging studies of hoarding, in which there are clearly some distinctive features of this problem that people, especially Dave Tolan, are looking at in various ways. So one of the challenges of working on a brand new problem is that there are no assessment instruments out there that were intended to measure hoarding severity or the features that are specifically associated with hoarding. So Randy and I set out with several other colleagues to work on this problem, and we worked at it from several different angles. And here what you see is that you need multi-method assessments, because the people who are encountering hoarding, who can assess it for you, need to have an instrument that they can use. This is the first one that we worked on. Randy developed the original version of this, and so we had to stick revised after it. So this is the Saving Inventory Revised, which is, and you'll see some of the data I'll show you on treatment, will show you that the cutoff score for hoarding is up there on the upper left at 41, with most people starting out in the low 60s in this on average. And then we're looking to get that score under a 41 in order to drop down into the non-clinical range. And that turns out to be a real hard problem. The hoarding rating scale is one that we developed early on. This is the quick and dirty version, best one to use if you want to be fast. There are only 5 items, and they really map on well to the DSM-5 criteria: clutter, difficulty discarding, problem with collecting, emotional distress, and impairment. And our favorite is the clutter image rating, and this is one of 3 pictures where we have 9 pictures of the living room, the bedroom, and the kitchen. And what you see here, the way you do this is first you talk your dean out of a few $1,000s so that you can rent an apartment. And then what you do is you get Randy to get a whole pile of students together so that they can walk across campus with all this stuff that they're carrying, including furniture for this apartment, who get stopped by the police en route, because what are they doing after all, walking with all this stuff? Then what you do is you bury students in the middle of the pile. You pile it all up and you bury students right in the middle of it, one of whom I believe was royalty in another country, as I recall. And then they pass things out to you. It took 36 pictures to get it to be, these are all, in fact, equidistant pictures, so your numbers 1 through 9 count for something. That was a lot of fun, actually. And then Jordana has worked hard with some of her engineering colleagues to make a downloadable app that's suitable for personal and community use, and now is in wide use in a number of contexts at this point. So anybody who wants the app, just go online and hunt for it. It's easy to find. We created the activities of daily living for hoarding because we wanted to capitalize on the behavioral parts of the problem that people with hoarding experience, so that we could influence them a little bit in the motivational realm to decide what it is they wanted to be able to do in life. Preparing food, using a fridge, eating at the table, exiting the home quickly. So that was just a few examples of the 15 items. And then we added a few more measures just for good measure here. The Saving Cognitions Inventory that Mike Kyrios helped with, the Home Environment Index that Jess Rasmussen worked on, the homes, which Christiana Bradiotis worked very hard on, especially to make it suitable for use in community settings and to assess the risk aspects of hoarding. And then a family response scale, and there are 2 or 3 of these floating around now. We probably need to all get together and develop one measure on that one. And then we need models for understanding how hoarding works. And so this is one that we've worked out. It's very similar to some of the OCD, BDD, and other related OC spectrum models, where we have vulnerabilities that we think contribute to the problem, information processing problems, and we're pretty confident of these at this point, beliefs and meanings that people attach to their stuff, and the emotions that are that occur when they try to acquire or try not to acquire, and when they try to get rid of things. And these lead to emotions that are quite powerful, both positive and negative, and I'll just show you some of those. This stands out. It's not like the anxiety and mood disorders because the positive emotions intrude frequently. So it has this kind of addiction quality to it in some respects, and is more challenging. And that means that we've got both positive and negative reinforcement driving the saving and acquiring behaviors. So it's a little bit of a double whammy and a very hard problem to work on from that perspective. I tossed in a behavioral analysis, so you could, Joe Wolpe would be very proud of me at this point, where we help people understand what's occurring in real time for them as they track how a trigger in the environment sets off that model for them in which they have certain thoughts, certain emotions, and certain behaviors, and how those happen over time. I won't go over the details of this, but you can see that acquiring is involved. And what about treatment? A critical aspect of this that is one of the most challenging aspects of it. What we know is that cleanouts don't work. And this is a study we did very early on, working with elder service providers in social service agencies. And we had 62 clients that they were thoroughly familiar with, and asked them what happened when cleanouts occurred. So you can see that unfortunately the no change bar is higher than any other at over 40%. Didn't change. The cleanout didn't alter the behavior. They just went right back to it. Clutter worsened in a few cases. Some people improved and relapsed, and only 15% benefited from it. So we've been trying hard to work with our colleagues in a variety of settings in the community to get them not to do a clean out, to get judges not to order a clean out for someone with a hoarding problem, knowing that it'll have a very temporary effect and be actually quite damaging to the person who is losing their stuff and has no say over what is taken out of the home. So a very serious problem that has taken some work in a little bit of the policy arena to deal with. So one of the things I want to point out is that the CBT piece of what I'm going to show you in the next several slides is only a piece of the pie. And I'll also show you some other strategies to work on the hoarding condition. And I made up pie slots here to just give a flavor of what some of the others might be. We have no idea at this point how much of the work should be done by clinicians and how much can be done by others. We have a lot of work to do to figure that out. I only know it's not the only piece of what has to be done for the problem. In terms of the CBT that we have developed, it's built on the model that I showed you earlier. We started out for our NIMH-funded study with 26 sessions based on that model. And those include, of course, assessment and case formulation, which we would do for any condition. Serious efforts to enhance motivation, not only at the start of treatment, but also throughout the process. Because what happens is that when faced with a decision about whether to acquire or not, whether to get rid of something or not, people are going to experience a lot of ambivalence on the spot. So we have to train people in motivational interviewing. And it turns out that you can not only train mental health clinicians in this, but you can also train community members in how to use these very effectively, especially some of the peer responders. In terms of other aspects of treatment, reducing acquiring is something that we used to do later in the game and have moved up to fairly early in the treatment in our more recent writings, because it's an area where it's possible to get a sort of good progress early in the game. Skills training is a piece of what we do in terms of organizing skills, problem solving, cognitive rehab strategies, and as Catherine Ayers will tell us, this is especially important for the older adults who struggle harder with some of the cognitive therapy techniques, which may not be the best way of going about it for a number of the adults that we're treating. So some of these skills training aspects seem critical to helping them move forward. Then we have to do lots and lots of practice with the sorting, discarding unwanted items, and this is the exposure aspect of the treatment. Cognitive therapy as it fits in to that exposure process in order to challenge the beliefs that they hold. And then preventing relapse if we can get them far enough along that we can try to prevent loss of progress. Here's that outcome of that waitlist controlled trial that used the 26 sessions of treatment with those individual items in it. And what you see here on the left is that the CBT treatment for the 41 people who experienced that was pretty successful. We dropped from that low 60s point down to roughly 44, 45 on that saving inventory revised, but remember that 41 is the line to get them below. So it couldn't get the mean below that line. And that's a continuing story. The wait list didn't work. Not surprising, that was the point. And the wait list only went out to the 12-week point so that we could have comparability, and then everybody went over into the CBT portion of the trial. If we look at the responder rate, what we see is that clinicians rate 71% of their clients as much or very much improved after the treatment. Clients were a little more optimistic at 81%. And in this study, we got a 41% clinically significantly improved rate. That number goes down a bit when we start to look at some of the other studies. This is so far the only study with these kinds of numbers for individual treatment for hoarding, as it is a not terribly cost-effective treatment in term. Well, what I should just say is it's costly. 26 sessions takes a lot of work. We did home visits on a regular basis for people, and so this is a little bit more challenging to do. Here you see the follow-up data for that study that Jordana did, and the numbers go down a little, but not a great deal. So 71 went down to 62, 81 went down to 79 in terms of the rating of much or very much improved. But here's the problem, is that this is about what that means on a practical level, with a tremendous amount of clutter on the left, which is where a number of people are starting, and significant improvement for that client on the right-hand side after treatment. But we're not really out of the woods, as you can see. So if we leave it alone at that point, what do we predict will happen? And that's part of the challenge. And in fact, it's fairly stable, so it's not a dreadful piece of it. There are many ways to deliver CBT for hoarding disorder, and I'll show you a few of them. I just wanted you to have a sense that we have a lot of options, and we're trying to figure out how to use those options. So this is a group treatment, and there have been several studies of group. Dave did a wonderful symposium this morning in which a number of those group treatments were highlighted there, along with a new one. And here's a study that Jordana did with home visits, more or less home visits, more on the left, and somewhat fewer, 8 versus 4 home visits. And then on the right, it's just a bibliotherapy where they're just reading a book. And you can see that bibliotherapy actually did improve a few clients, but it works better to deliver an actual group treatment containing the CBT elements that we have. And again, with home visits, we're getting close to that 41 line, but we're not really there. The BIT workshops have been developed by Randy Frost and Lee Schuer. And Lee is a sort of a master facilitator for these, a peer himself with a hoarding problem previously, so well experienced at it. And Randy's done a few studies of this, so you see that these are 15 weeks, so they're shorter treatments, whereas I should have said that the group treatments have ranged from about 16 weeks to 20 weeks. It's varied a bit over the studies that have been done, with about 6 to 9 members per group. And as you can see from the little graph that's up here, waitlist doesn't accomplish much, as we would expect, and the Buried in Treasures workshops that are led, and these are more of an educational format rather than this is not clinician-led at all. These are peers working together with a peer leader. The saving inventory drops again from that high in the 60s down close to that clinical line, but not quite under it. And here's a group of studies showing a meta-analysis that Dave and we colleagues worked on together, looking at the percent of people, the percent of SIR, saving inventory reduction, for these treatments. And you can see that they are variable depending on which study, but they're all in the same general ballpark. And what we're not seeing is the 40 and 50% range that we would like to see there. It might be easier to improve acquiring than clutter, although the jury's out on this right now. What you see in this is that meta-analysis in terms of the degree of clinically significant change, a little bit higher for that acquiring problem than certainly for the clutter problem. That makes a bit of sense. Acquiring happens in the moment, a little easier to get a handle on with a lot of practice in non-acquiring practice. And clutter, however, takes longer because it takes time to do that sorting. So that comes along less quickly. I suggested and worked with Jordana on this study. We were trying to figure out whether we could find patterns in the data. And this is something that Edna Foa taught me many, many years ago. When you have people take a look at the individual data, let's get away from the means for a little bit and just see what's happening to actual people in terms of it. Now, this slide, of course, looks like a god-awful mess. And so, but you have to, and then you have to go in and try to figure out what are the patterns that seem to hang together. And when she did that, she found bricks and seats. And so it turned out that about half of the sample just flatlined it, not much improvement over time. And whereas another half of the sample got a lot better and held on to that. There were only a couple people who got better and then got worse, just a couple in the sample. And again, another couple that got better and better. So this is interesting, and then you have to try to figure out whether or not this predicts anything. Can you find who these people are? Who are the people who flatline it, and who are the people who get better and hold on to it? Because that could help us a lot figure out where to go. And so Jordana looked at that, and Dave Tolan has also looked at that in the meta-analytics study. We find no particular effect of individual versus group, clinician-led versus peer groups, or depression. What we are finding so far is that women appear to do better than men, and we don't know what that's about. That younger may do better, especially on acquiring behavior, and maybe that's something about compulsive buying, we're not sure. And then the jury's out on some other areas. Lower initial hoarding severity, perfectionism possibly, so more work to be done in those areas. So I want to bring us back to the network of people that are involved in this process and take a little bit of a look at other angles on doing this treatment. And so as we think about that, housing inspection for a number of people, because this is a population that tends to be lower income, and especially for the non-voluntary clients, they're often going to be found in some of these arenas. So it's a rare opportunity, or perhaps not such a rare opportunity, for us to see what we could do in that context. And Jessie Edsel-Vetter has worked as a housing inspector within the Boston Housing Partnership, has obtained quite a chunk of funding from the Oak Foundation, now a new chunk of funding from another one, and so there are other studies ongoing. And this is their first pass at it with 175 clients at risk of losing their housing subsidy or at risk of eviction. And what you can see is they're similar in being middle-aged, but there are many more men, and I didn't happen to mention that many of our treatment studies have more women than men, and we're surprised at that because we understand there are plenty of men out there with the problem. A larger sample, it's a more diverse sample, a lot of whom living alone, lower income people. And what happens as he works on this problem with his colleagues, and they have a whole hoarding unit as part of this housing organization. So they used an intervention that focused on harm reduction. Whatever the risks were in the household, they would work on reducing that. Modified CBT techniques, they came for training. We worked closely with them. They're highly skilled at using those CBT methods in ways that make sense in a housing context. A lot of case management and working with housing partnerships so they can refer for various problems, and ongoing monitoring for a full year after the person completes the program, with outcomes in which only 2 people out of the 175 lost their housing because of hoarding, which is a tremendous improvement over what they had been seeing. Significant clutter reduction that actually looks pretty similar to what we can get when we use a CBT treatment. Now, they're working with involuntary clients, whereas we tend to be working with voluntary ones. 43% were able to pass inspection, but 23 people dropped out before they got that far. So there's ways to go here to improve it. What they've concentrated on is the training process. So their training at this point has reached out to, we're pushing 2,000 professionals who've been trained in how to use these intervention methods to treat hoarding. And replication sites now with the new funding across 3 states, but the training has pretty much crossed the US and Canada, as Christiana, Jesse, and many others are now running across the country trying to implement the training strategies. I also want to mention community task forces, where multidisciplinary assessments and interventions are the order of business. Christiana and Sheila Woody are working very hard on this up in Canada and across Canada at this point, as well as in the US. And I'm just going to give a flavor of it. I don't have data. I'm waiting for them to give me data that I could then use in the future. And so you can see that the task group, they're hoarding task forces across the country, again in the US and Canada. There's a ton of them in the Boston area because we've been actively working on that. And in this you see that many of the little, that array of people that are from the service sector and the community sector are involved in these efforts to improve the hoarding problem. They come at it again from the health and safety end of things, where they're trying to prevent eviction, fires, ensure a safe environment, and ensure the safety of anybody going into the home. And they're going to work on the health aspects of it, using an engagement strategy where, for example, in some case, the property manager or the fire inspector might make the initial visit to get a foot in the door, and sometimes it's almost literally a foot in the door. Clients work with mental health staff and make repeated visits to the home in order to fully engage. Now remember Irene. I showed you 3 pictures of Irene's house early on, and Randy and his students worked with her for about 1.5 years. And this is what they succeeded in doing. So, of course, it's a lovely home, but that's really hard to achieve. This level of improvement is not what we typically succeed at. And that took 1.5 years, and maybe that's part of our problem as we keep trying to do it in shorter periods of time. So that's a very serious question to us. And we have to remember that clutter removal is only part of the goal, because there's a complex array of pieces of the problem that are going to make these people's lives quite difficult. So together we have to find more effective strategies. And a question is, what's next for us in the field of hoarding? And everybody's working pretty furiously on this problem. A better understanding of hoarding behavior across the full range of the symptom patterns that people have, the contexts in which they live, including the non-voluntary clients, because those are often the ones at highest risk. Animal hoarding is another one that we have a tremendous difficulty studying, but it is a thoroughly difficult problem that probably borders on the serious mental illness aspects in other areas. And so that's one that I know Catherine and Christiana have started to work on, but is a hard problem. Collaborative efforts to develop cost-effective and efficacious, probably stepped care algorithms for individual treatment. When do we need that? When will group treatments move us forward? When would web-based strategies, and Jordana is working on webcam in the home, clinicians in the office, clients in the home, with web cameras so that you can actually see what they're working on at the time. Terrific idea. We're in the case study level of that work. Family interventions, and Greg Chasson is working on this, peer interventions, as I've described, and the community interventions. So we have a big array of options, and we have to figure out how to use those to maximum effect to get down into that non-clinical range and keep it there. And of course, public awareness, so that it's not just, you can throw it out, I know you can, and a lot of training for those who are involved in it. I'm going to stop at this point. Before I do, I want to thank my wonderful husband, who's sitting here in the front row, for helping me put all the pictures on these slides. He's much better at it than I am, so thank you very much. Yes. And thanks to my wonderful colleagues who've helped me with this work. Thank you very much for your time and attention.
Many thanks, Gail. This was a fantastic talk. And now I have the pleasure to give you this gift on behalf of the association for your outstanding leadership. Thank you very much.
Thank you.
And thank you all.